Good morning and good evening, fellow doctors and colleagues. For today, Dr. Sheng-Po Hao Retirement Virtual Webinar, we're honored to introduce Dr. René Leemans as our invited speaker. Professor René Leemans is the chair of the Department of Otolaryngology, Head and Neck Surgery at Amsterdam University Medical Center. He is the director of Advanced Fellowship Program in Head and Neck Surgery and Oncology at VU University Medical Center, Amsterdam. His special interests include head and neck oncology, reconstructive and microvascular surgery, and basic research. René Leemans has made a substantial and international recognized contribution to cancer care and research in the field of head and neck oncology over the past decades. His scientific standing has been recognized by election as president of the Netherlands Society of Otolaryngology Head and Neck Surgery and the Dutch and European Head and Neck Society. He also serves on the leadership of American Head and Neck Society. He authored more than 500 papers and books chapters on head and neck oncology, and is regularly invited to speak at internationally conference and tutor at course. Today, Dr. René Leemans' presenting topic is quality of care in head and neck surgical oncology. Please give a round of applause to welcome Professor René Leemans.
Hello, my name is René Leemans from Amsterdam, and it is a pleasure to address you for this webinar to celebrate Professor Sheng-Po Hao's career. This lecture is about improving quality of care in head and neck oncology and surgery. And here is my disclosure, nothing to do with this talk. Why is having a high quality of the performance important? Because we have usually the best goal to treat patients in the first instance. Here you can see the graphs of Jerry Goodwin some 20 years ago, and he already noted that treatment for recurrence of head and neck cancer, be it previous surgery or radiation, has a fairly moderate to dismal outcome. The best is probably for larynx, but the other sides look much worse. So a high quality in the first instance is important. In this talk, I will follow the well-known factors that compose quality, that is structure, processes, and outcome. Examples for structural items are the role of the surgeon. Is he well trained? And what is the effect of the amount of surgeries performed? Processes, we can look at checklists, guidelines, the effect of timing of treatment, the nodal yields of the neck dissection specimen, and the effect of margins. The third factor, outcome, is important because based on outcome we can further improve our future treatment. Starting with the role of the surgeon, it's interesting to note that some centuries ago already Benjamin Franklin noted to be aware of the young doctor. That means you have to have a doctor with a certain amount of experience. It's also interesting to note that throughout the patient journey, the head and neck cancer patient journey, the surgeon plays a central role and is involved in almost all the stages, be it diagnosis, therapy, rehabilitation, complication management, the follow-up, salvage if needed, palliation if needed, but also in preventing new primaries and treating second primaries if they occur. So this more or less testifies to the very central role and important role the surgeon has. So what is a surgical oncologist? It has been defined by Rees in 1997 as a surgeon who knows when to operate, but also when not to operate. And he should also have a broad knowledge of the other cancer disciplines. And that's very important to know what the other discipline with whom we are in the multidisciplinary team can offer to the patient. So what is a well-trained surgical oncologist in the head and neck? This is just an example of an addition to the regular training that we have in the Netherlands, a 2-year fellowship that started in 1998 and was further updated in 2015. It's a combined program for both the otolaryngologist and the maxillofacial surgeon. It consists of a modular approach, oral cavity, oropharynx, nasopharynx, larynx, hypopharynx, oropharynx, and nasal cavity, and reconstructive surgery, and also skin tumors. It's not necessary to follow all the modules, but the basic modules, of course, have to be followed, be it a otolaryngologist or a maxillofacial surgeon. This is an important other well-known initiative coming out of the International Federation of Head and Neck Oncologic Societies, the so-called Global Online Fellowship, GOLF, and that is an initiative, a collaboration with Memorial Sloan Kettering Cancer Center, Jay Shah, that started some 10 years ago and entails 2 years of self-learning and online examination. The last is a case-based oral examination. And although this is not a hands-on examination, the theoretical knowledge of the future head and neck surgeons is also important. And some 400 or more graduates have came out of this program until now. What is the effect of volume? Here we can see already 10 years ago that there is a relation between volume and outcome. And here we can see the survival is better if the surgeon does, let's say, more than 20 cases per year. And the same goes for the hospital, that should have a certain amount of cases to be able to provide the best care for the patient. This is to show the hospital volume in relation to complication rate, and big study, cross-sectional study in the United States. We can see that low volume hospitals do worse in terms of morbidity, mortality, and length of hospitalization than the higher volume hospitals. Another American study, large study again, showing that The more procedures per surgeon, total laryngectomy in this case, are performed, the better the outcome is for the patient. And here a cutoff of 9 cases per year was taken. How can we acquire higher volumes per center and per surgeon? That's by centralization. In the Netherlands, with some 18 million inhabitants, we have done that for the last 40 years by self-regulation to start off, but in the latter years it was more or less impinged by the authorities. That means there are 8 head and neck oncology centers, 7 university hospitals and 1 cancer hospital, and 6 so-called preferred partners that are allied to one of the main centers. The minimum number of cases is 200 per year of oral cavity, oropharynx, hypopharynx, and larynx. And most centers, I think it's fair to say, have 1.5 or twice this amount of new patients per year. In total, there are more than 3,000 cases every year in our country. Another important factor is the impact of the multidisciplinary team. This is something that has been regulated by many constituencies. In the last 10 years, patients are oftentimes not allowed to be treated outside of MDTs. And this is a study showing for the advanced cases out of Australia that patients seen in an MDT fare much better than those who aren't, and are also more likely to receive combination therapy compared to the patients that are not seen in an MDT. Another study showing the same is out of Fox Chase Cancer Center in Philadelphia. They instituted their MDT in 2011, so they were able to compare their older series of patients as to survival to the latter series in which the MDT was instituted, and we can see that patients in the latter periods fare much better. And if the MDT as such has an effect, surely the volume of an MDT also has an effect. We were able to show this in a retrospective analysis of the patients referred by our preferred partner in Amsterdam, the so-called NWZ group in the north part of the country. All these patients were again discussed in our central MDT, and we were able to compare the original recommendation of the low volume MDT with our recommendations, and it was shown that there were changes in about 22% of the cases, and that may have been major changes in 17% or minor changes in 5%. And these changes may have been intensification of treatment in the majority of cases, or de-intensification of treatment in 38% of the cases. Another process indicator is, of course, the timing as counted from the day of diagnosis, the treatment. And this is a study out of the eastern part of our country from Nijmegen, and they were able to show a comparison between their original conventional workup and their fast-track workup. And they were able to show that if you received your treatment within the first 30 days after diagnosis, the hazard ratio of survival was about 2 better as compared to the patients that had a longer time to treatment. Another study showing basically the same, but in a much larger sample of about 500,000 patients. And here there was also an effect of a positive effect of treating within the first 30 days, but especially within the first 60 days of treatment. Complications, another important measure. We can see here a single institution series of total laryngectomies, fairly large numbers. We can see that if complications occur, the outcome is worse. Guidelines, there are many guidelines out there, and this is from MD Anderson, and they looked at patients that were referred to them and looked whether the original treating institute has followed the guidelines, they were compliant with the guidelines, yes or no. They came to the conclusion that a fair number of patients, some 43%, were treated not according to the guidelines at that time, and that could have been inadequate surgery, inadequate adjuvant therapy, inadequate radiation, or even misdiagnosis, or patients that refused the recommended treatment. There are also guidelines as to the follow-up of our patients, and here is a single center study showing in a very large series that there was really not a great effect of adherence to the follow-up guidelines within the first 5 years, but thereafter there was an improved survival if the guidelines were followed. The effect of negative margins, very clear outcome of our surgical performance. We can see that patients who have at least a 1 millimeter margins in oral tongue cancer, early stage oral tongue cancer, do well. But if there is irradicality, and even if the patient is treated with adjuvant radiation, the outcome is worse. Incision in the tumor is a very bad thing, and then outcome, that's the yellow line, is dismal. Nodal yield of our neck dissection, another process indicator. Already in 2011, in this series, we can see that there is an independent prognostic factor for overall survival. So the more nodes you remove, the better the patient fares. And here a cutoff of about 18 nodes was found to be prognostic. And this is a later study, a meta-analysis that looked at the cutoff of 18 nodes again, and they were able to show a significant effect of survival in many studies. Even when you remove more nodes, 19, 22, 25, the patients fared better, but 18 is an important measure of the quality of your neck dissection. We now shift to the improvement of outcome by auditing. If you look at your own results, you will be able to improve on your performance to the benefit of the patients. There are numerous initiatives around the world. I just put a few here, the so-called NSQIP program in the United States. There's in the Netherlands, we have the Dutch head and neck audit, and in Australia and New Zealand, they have the otolaryngology head and neck surgery pan-national audit. And it's important to realize that if you look at your own results, you will be able to improve. And I've put an example here on the next slide. In the Netherlands, by just looking at the waiting time for the individual head and neck centers, we were able to improve on the waiting time to treatment. The red line indicates the famous 30-day border. You can see in the previous years, we weren't always able to achieve this 30-day border, but in the latter years, in general, as a mean, we were able to reach this 30 days. So only looking at your outcome, you will be inclined to do better. Another study out of the United States on the basis of the National Cancer Database, some 76,000 people treated for head and neck cancer, and they were put into quality criteria, and they consisted of negative margins, more than the 80 nodes, adjuvant radiation if needed, adjuvant chemoradiation if needed, and start of the adjuvant therapy within 6 weeks if patients' centers complied to these criteria. They were put in the high quality group and otherwise in the low quality group. And here again, you can see that the high quality performing institutes gave better outcomes for the patients. And this is the value-based healthcare. Here we can see that the outcome multiplied by the patient-reported outcome and the experience measures divided by costs and the effort to put in is the value. So we should always aim to increase this value, and this is Porter, one of the original proponents of the strategy called value-based healthcare. So at the end of this presentation, we have to realize that to improve the quality of care in head and neck cancer surgery for our patients, we need to have a fellowship-trained surgeon or otherwise well-trained surgeon, a high-volume center who can do that with centralization. We have to have a well-functioning, high-volume multidisciplinary tumor board, and we have to monitor our own outcome in order to improve further on our performance. And with this, I'd like to draw your attention to the ECNO meeting we are throwing next year in Amsterdam of the European Head and Neck Society, biannual meeting, a big meeting. Registration is open. It's at the end of March, and I would urge you all to come to visit Amsterdam and to take part in this important meeting. And as you can see here, Dr. Sheng-Po Hao is already very enthusiastic because he is one of the faculty members. And with this, I thank you for the privilege of the floor, and thank you for your attention.
Thank you, Professor Reemans, for a very comprehensive talk about the quality care of head and neck oncology. Now we open up to the floor for discussion. Is there any questions or discussion need to make?
No meeting.
Well, thank you, Professor René Leemans, for a wonderful talk. And he talked about the high quality care and how to achieve the high quality care in head and neck oncology, surgery, oncology and surgery. And certainly he brought several good points that well-trained surgeon and large volume multidisciplinary care, and then the review of the auditing, the review of the your care, and that's the proof of the high quality cancer care. So thank you very much for Professor Leemans. I guess there are a few because I forgot to announce this meeting in the international board. So I guess there might not be too many attending this this meeting, but I think the Chumin is online. Chumin, would you like to say something?
Hey, hi, Peter. Yeah. So
yes.
Yeah. Thanks so much. I got it was a nice summary how to improve the in a very systematic way the quality of care for head and neck cancer, because it is quite a challenging field, oncologically wise. And I think he also mentioned about the surgeon oncologist is a bit different from just surgery. A surgeon oncologist will need to understand the entire broader view of oncology care for head and neck cancer patients. I thought it was a very comprehensive overview of quality of care and how do we implement as well as monitor the institutional results. Yeah.
Yeah, and I guess in Netherlands they are more centralized in the head and neck cancer care. I think that's probably the same in Singapore, right? I think in Singapore you have two major head and neck cancer hospital. One, and you work in both actually, as I understand, right? Chumin.
Yeah, so I guess the multi-tumor board is really helpful because as surgeons, sometimes our treatment decision may be very surgically biased. So it's really helpful to hear from the other colleagues in the oncology, like radiation oncology and medical oncology. And I think this is quite a standard practice in Singapore, where most of the cancer, head and neck cancer, get presented. So I thought that was one of the take home that he also mentioned. And also in Singapore, we also participate in the NetSquid initiative that Prof. Leemans presented. So that kind of give you an overview how your results compared to the NetSquid data, which is I think a primary American data set. So you can see how your complications, your results compare in relation to in the United States. So I think these are the few things that we are kind of practice in Singapore context. Yeah.
So thank you, Leemans. Thank you, Professor Leemans, and thank you, Chumin, for your excellent comments. And is there any question or any comments from the floor? If there isn't, we are going to close the last. This is actually the last two, retirement virtual webinar, and then we are going to have the last one, which will be at the December 30th by our Professor Kwan Yung Kim, and so I hope everybody could be online to listen to the last talk to celebrate my retirement. So thank you, Chumin, for your comments, and of course, thanks to René Leemans, and who was Miles' lecturer 2 years ago, and so really a very good friend. And we have we are going to the his meeting in Amsterdam next March. Amsterdam, the EHNS meeting. I just booked my flight yesterday. Yes, and so hopefully we could have a very good combined national and EHNS meeting. So thank you again for all the participants. We are going to close the retirement webinar now. Thank you, and have a good day, everybody. Bye-bye.